On behalf of the GS0112 study team, I'd like to thank the organizing committee for allowing us this opportunity to present the week 48 renal and bone safety results in this trial of HIV-1 infected participants who are virologically suppressed and switched from their TDF-containing regimens to a regimen containing tenofovir alafenamide. My disclosures are listed here. The parent nucleotide tenofovir, or TFE, is the active moiety that inhibits viral replication in HIV target cells. However, TFE cannot be systemically absorbed from the GI tract. It requires incorporation in a prodrug such as TDF to gain entry to the systemic circulation. However, TDF is immediately cleaved to TFV in the circulation with only a small proportion actually entering HIV target cells. However, the novel prodrug tenofovir alafenamide, or TAF, is an amidated prodrug that not only gains entry into the systemic circulation, but then is taken up by HIV target cells unchanged, thereby leaving only a very small residual amount of TFV in systemic circulation. In fact, the 91% lower plasma TFV levels achieved with TAF versus TDF has previously been shown to minimize renal and bone effects while maintaining high potency for suppressing HIV. Therefore, with these potentially beneficial aspects of TAF versus TDF, it stands to reason to ask the question if a TAF-based regimen would be safe and efficacious in patients with pre-existing renal dysfunction. Therefore, 0112 was designed and is actually still ongoing as a single-arm, open-label phase 3 study of HIV-infected participants with mild to moderate renal impairment, defined as having an estimated GFR by the Cockcroft-Gault equation of 30 to 69 milliliters per minute, who were then switched to single-tablet ECF-TAF. We have previously demonstrated earlier this year in the overall cohort that there were no changes in actual GFR in this trial, but there were substantial and significant reductions in total and tubular proteinuria and improvements in bone mineral density. Today, we present the 48-week analysis of renal and bone safety markers in two pre-specified subgroups of participants receiving either TDF prior to switch to ECF-TAF or from their non-TDF containing regimens before making the switch. The study design of the parent trial of 0112 is shown here. Again, this is an ongoing phase 3 multi-center open-label study of patients who are virologically suppressed, switching from TDF or non-TDF containing regimens to single-tablet ECF-TAF. The primary eligibility criterion, besides being virologically suppressed, was having a stable estimated GFR by Cockcroft-Gault of 30 to 69 milliliters per minute. The primary endpoint was change from baseline in eGFR at week 24. Actual GFR was assessed by Iohexol clearance methods in a participant subset. Today, the week 48 data are presented by pre-switch TDF use. Please note that we're presenting within-group comparisons to understand what specific changes might have occurred based on their pre-switch regimen. Between-group comparisons were not performed as the pre-switch regimen was not randomly allocated and there were substantial baseline characteristics imbalances, primarily due to treatment indication bias. The baseline characteristics of the total cohort of 242 participants in these analyses and in the two subgroups of interest are shown here. The median age between the TDF and non-TDF subgroups were similar. Please note that there was a substantial number of participants who were older than 65 years. Though there were somewhat fewer of these participants in the TDF subgroup, there were more frequent women and blacks in the TDF subgroup and a higher CD4 count in the TDF subgroup. There were fewer participants with hypertension and those who had TDF prior to switch, though there were similar numbers of those with diabetes in both subgroups. Interestingly, the median eGFR was higher in the TDF subgroup, likely representing a greater comfort level of providers to continue to use TDF in higher renal function levels. Not unexpectedly, there was more frequent grade 1 dipstick proteinuria in those receiving TDF prior to switch, though the levels of grade 2 proteinuria were similar between the two subgroups, and no grade 3 or 4 dipstick proteinuria were observed in the entire cohort. The pre-switch antiretroviral treatment regimen components are shown here. nearly 2/3 were receiving TDF prior to switch, 22% were receiving abacavir, 7% other nucleosides, and 5% were not receiving any nucleotides in their regimen. 44% were receiving protease inhibitors as their third agent, 42% an NNRTI, nearly a quarter were receiving an integrase inhibitor, and a few participants were receiving a CCR5 antagonist. Actual GFR by iohexol clearance through week 24 is shown here. In the total cohort shown in purple, the TDF subgroup in orange, and the non-TDF subgroup in green, there were virtually no changes in actual GFR measured by iohexol clearance. In fact, the geometric least square means ratios from baseline to either weeks 2, 4, or 8, or from baseline to weeks 24 were well within the pre-specified lack of alteration boundaries of 80 to 125%. Therefore, actual GFR was unaffected by ECF-TAF switch, regardless of previous regimen. The estimated changes in GFR from baseline to week 48 are shown here. From left to right, we estimated GFR using 3 equations, Cockcroft-Gault, CKD-EPI, and then CKD-EPI cystatin C. The baseline values of estimated GFR are shown above this horizontal set of lines. In general, we saw very small changes in estimated GFR regardless of estimating equation used. However, the direction and magnitudes did change and vary depending on which equation was used. In general, there were greater increases or lesser declines in estimated GFR in the participants who were receiving TDF prior to switch. Changes in proteinuria from baseline to week 48 are shown here. 4 urinary measures of proteinuria were assessed. Total proteinuria, or urine protein to creatinine ratio, urine albumin to creatinine ratio, and 2 more specific tubular markers of function, either retinal binding protein to creatinine ratio or beta-2 microglobulin to creatinine ratios were assessed. The baseline values for each of the markers in all of the groups are shown above the vertical bars. As you can see, the values of each urinary marker were substantially higher in the TDF group compared to the non-TDF group. However, through 48 weeks of treatment with ECF-TAF, there were substantial and significant reductions in each of these urinary markers in the total cohort, with the 48-week levels shown within each vertical bar. This was driven primarily by significant reductions in each marker in those participants who were receiving TDF prior to switch. Of note, the week 48 levels of each marker in the TDF subgroup seem to approximate those in the non-TDF subgroup after 48 weeks. Showing the same data, but by categorical definition, with clinically significant proteinuria, defined as having a urine protein to creatinine ratio over 200 milligrams per gram in red, you can see that the proportions of participants who had clinically significant proteinuria in the total cohort statistically significantly was reduced after 48 weeks of treatment with ECF-TAF, and this was driven almost exclusively by reductions in those proportions in the TDF subgroup. Clinically significant albuminuria was defined as having a urine albumin to creatinine ratio of over 30 milligrams per gram. Again, nearly half of the total cohort had clinically significant albuminuria at baseline, which was then substantially and significantly reduced after 48 weeks of switch to ECF-TAF, again driven primarily by those participants who were receiving TDF prior to switch to ECF-TAF. The changes in bone mineral density from baseline to week 48 are shown here. In purple, you can see that the changes in bone mineral density at the spine and the hip were significantly increased in the total cohort, driven primarily, once again, by those participants who were receiving TDF prior to switch to single-tablet ECF-TAF. It should be noted that there were smaller increases in bone mineral density at both spine and hip in those participants not receiving TDF prior to switch, though these changes did not reach statistical significance. The changes in fasting lipids through week 48 are shown here. There were significant increases in total cholesterol, LDL, and triglycerides in the TDF subgroup. However, there were significant declines in total cholesterol, LDL, and HDL, but not triglycerides, in those not receiving a TDF-based regimen prior to switch. Of note, the total to HDL cholesterol ratios were similarly increased in both groups. In conclusion, participants receiving TDF prior to switch to single-tablet ECF-TAF had no change in actual GFR, but did have significant improvements in urinary markers of renal function, significant improvements in bone mineral density at both the spine and the hip, and significant increases in lipids, which is consistent with the independent effect of circulating TFV on reducing cholesterol levels. Participants not on TDF at time of switch had no changes in actual GFR, had stable urinary markers of renal function as well as bone mineral density, but did have significant decreases in cholesterol fractions. These 48-week data support the renal and bone safety of using a once-daily single-tablet regimen of ECF-TAF for adults with virologically suppressed HIV and pre-existing renal impairment down to an estimated GFR by Cockcroft-Gault of 30 milliliters per minute. I would like to thank all the site investigators, the study staff, and of course, all of the study participants in this trial for their contributions. I'd be happy to take any questions. Thank you.
So we'll start with Jens at microphone 2.
Yeah, hi, Jens Lundgren, University of Copenhagen. Samir, thank you very much for a clear presentation. One thing that I was unclear about was that study entry in those on tenofovir, which clearly had low eGFR. Were the dose of tenofovir actually reduced as a consequence of that low eGFR, or were they maintained on the regular dosing as study entry?
No, that's a good question. So if their Cockcroft-Gault or creatinine clearance was about 50, they would be on normal dosing. If they were below 50, they must have been on the appropriately dosed every other day dosing of TDF. So,
but were they?
Yes,
okay.
That was an entry criterion.
Okay. My second question relates to the fact that obviously the people you're entering have other predisposing factors for getting their eGFR low. And I guess to some extent your data is raising the question about whether these markers of tubular dysfunction are actually just an epiphenomenon, since the eGFR is not changing. And in another way to say this is that people have progressed for other reasons, and tenofovir was not part of the contribution, and therefore that it really didn't help them to switch away from that. As a nephrology expert, what would be your comment on that?
No, certainly the easy answer to any such question is that it's multifactorial. I think certainly HIV infection, even when virologically suppressed, will contribute to these elevated markers compared to HIV negative comparative controls. I think the question of epiphenomenon is interesting. I am only aware of one paper that has made any link between, say, proteinuria and future development of declines in GFR. And so most other studies which are cross-sectional have not shown those associations, similar to the question that was asked during the previous presentation. So the clinical relevance of these increases in urinary markers are questionable if they are just attributable to TDF, but if switched to TAF and you get a quote-unquote normalization to levels found with other regimens, they're still elevated and still have to strongly consider other comorbidities, diabetes, hypertension, hepatitis C, that might be predisposing these patients to a future renal function decline.
Okay, Giovanni
Guaraldi from Modena, Italy. You showed a very nice reduction not only in protein-creatinine ratio, but also in albumin-creatinine ratio. What is the mechanism by which you believe albuminuria may decrease, and what was the prevalence of hypertension in this cohort?
So the prevalence of hypertension, I can go back, but it was roughly, I think, 13-15% in the entire cohort. I have to double check the baseline characteristics. The question of why would a switch from TDF to TAF result in improved albuminuria, I think we generally understand of albuminuria reflecting perhaps a specific glomerular dysfunction, and you would not expect a glomerular dysfunction to improve with that switch. But albuminuria is also a proximal tubular function marker. So albumin is not only filtered, but then taken up by the proximal tubules. And so it actually is not as specific as we may hope in that regard. So it is not as clean a tubular marker as RBP or beta-2 microglobulin may be. So my speculation is that we're seeing an improvement generally in PR function, and that's why you see the improvement in albuminuria.
Okay, 2 last quick questions and quick answers from microphone 2.
So Sylvia Guilherme, Vancouver again. You have shown some small but significant changes in bone density as well the previous author had presented in these patients. We know that that can be, the bone density study has variability and is dependent on interpretation. I wonder if you have assessed bone metabolism markers like enteropeptides or other calcium metabolism markers that actually would be more reliable in terms of assessing bone health.
No, that's an excellent question. Those markers were collected but have not yet been analyzed. So hopefully I'd be able to answer that question to you in the future.
Okay, last question.
Ricky Su from NYU in the United States. Question regarding the improvements in the proteinuria and albuminuria, as well as beta-2 microglobulinemia. In studies 104 and 111, what we had seen was that the protein levels had significantly improved in a very short period of time, in the first 2 to 4 weeks upon going onto a TAF-based regimen. In this study, when did you see those protein improvements occur? Was it also within the first months? And if it really happened in the first months, what would you propose as a possible mechanistic reason for improvements from a proximal tubular level?
No, that's a wonderful question. So these markers were assessed more frequently, so not just at weeks 24 and 48, and they were measured early on, similarly to the other TAF trials, and those reductions were seen early on as well. So it's a very interesting question. We did not perform biopsies to assess histopathologically if proximal tubular function showed morphologic improvements. Could it be that we're sort of taking the gas off of mitochondrial dysfunction with TFE in the proximal tubular cell, and that there's energy imbalances that are resulting in quick improvements? Again, that's speculation at this point, but I think it would be worthwhile to follow up with other mechanistic studies.
Okay, thank you.
Thank you. Moving on, the next presentation is